Okay, good afternoon. So my name is Peter Mannion. I'm the Public Health Services Manager within Bridgend, but we also work across the ABMU Health Board. I'm giving the presentation today, I think, because I've drawn a short straw, but this programme is very much a partnership between the local authority, the Health Board, Public Health Wales, the third sector in the form of HALO, who's our leisure providers. They're the service provider for all of our leisure facilities within Bridgend, and the private sector in the form of Weight Watchers. Any one of the organisations, any one of the officers or managers from those organisations could be given this presentation as well. Okay, within NHS Wales, it's estimated that we spend over £73 million per annum on obesity-related illnesses. The Bridgend North Community Network, where this programme is based, is a multi-sector health and social care community, a community-based team covering the three valleys within the north of Bridgend. That's the Flimley Valley, the Garrow and the Ogmore, plus the gateways to the valley area. So it's, if you can picture the area of Bridgend, it's all of the area that's north of the M4. The North Community Network has the highest European age standardised rate prevalence for coronary heart disease, diabetes and hypertension within our health board region. Betus within the Garrow Valley is ranked 56 out of 1,896 areas in Wales within the Welsh Index of Multiple Deprivation, 12th within the Health Index. This programme is all based upon an integrated programme that exists between our health and leisure services. HALO, who I've mentioned, recently have taken over our leisure services, but we've had a long established integrated model between leisure and the health service. And this programme sits within a suite of other services, which today there's not time to go into, but it's important to understand that it sits within that context. This is the programme that we run. There are four key elements to the programme, and in understanding the programme, often people are focused only on the use of the private sector and Weight Watchers. Oh, sorry. Thanks, ma'am. Often people are only focused on the use of the private sector and Weight Watchers, but we're very clear that there are four very clear elements to it. That the buy-in and leadership that's provided by primary care is essential to the programme. The Weight Watchers element and the use of their NHS scheme has been an essential element. The exercise referral scheme, or the NERS scheme as people will recognise from other parts of Wales, is a key part, and also linking people into wellbeing brokers, which I can explain about towards the end of the presentation, is a key element as well. I'm going to put my phone somewhere just in case it's that that's causing a sweet thing. The approach taken has been to provide effective motivational support and education through swimming club, allied to exercise programs and signposting to local groups through the local community. This approach is innovative because of the integral role, the way in which we've integrated these elements together. So moving on to the evaluation, we undertook a multi-method service evaluation with descriptive data analysis, and this was supported through Swansea University. Descriptive analysis of cardiovascular parameters and sub-analysis of diabetics and non-diabetics was undertaken as well. The focus was both on the initial pilot participants, that was 66 participants, but we've made a comparison to a larger cohort of 216 participants that have been running within the programme between September 2010 and December 2011. The evaluation questions were: how suitable is the programme to participants and staff that are involved? Does participation in the programme lead to a significant 5% weight loss after the first 12 weeks of the programme? How effective is the programme in reducing cardiovascular parameters? Has there been a reduction in prescribing of anti-obesity medication? And does the programme equip participants with knowledge, skills and confidence needed to maintain a healthy lifestyle? 80% completing 10 or more weeks of the Weight Watchers 80% completed 10 or more weeks of the Weight Watchers programme, and 58%, nearly 6%, took up the exercise on referral programme. Patient stories have shown us that there has been a significant impact on confidence and social support and reducing social isolation for the participants. 54% reached their 5% weight loss, and consumption of five portions of fruit and vegetables per day is increased. We've also seen an increase in memberships of leisure centres, and that's for us a key element because it's an incentive for leisure centres to be involved in this. Around 30% of all those who are finishing the programme are taking up leisure memberships after the programme. These are people who are, if you think of the spectrum of physical activity, these are people who are most sedentary within our population. They would never be taking up leisure memberships prior to this programme. We're going on to pay for a membership afterwards, which is a good business reason for partners to be involved in this programme. At 12 weeks, there was a significant reduction in weight, waist circumference, and BMI. And the diabetic group experienced a significant reduction in mean HbA1c levels from a baseline of 6.9 to 6.2. We've also seen the prescribing of the anti-obesity medication Orlistat decreasing. Okay, conclusions and lessons. Without a doubt, essential to this programme is primary care ownership. The GPs and primary care practices have very much taken a part in owning this programme, in encouraging participants to consider this programme before going on to Orlistat medication. They also sign a contract with the participants and then monitor their patients over the period of the programme. The individuals are required to make sustainable lifestyle changes and through the contract be committed to this programme. We're committed to continuing to develop this programme within ABN, and we're currently working up a business case for rolling this out across the Bridgend locality. And we're doing this based upon savings within prescribing costs, and I can go into some of the detail around that if required. We're looking not just, there isn't the money just from the savings within Orlistat, but when you tie that into other savings within blood pressure, drugs, within cardiovascular, other cardiovascular medication, that we can see the savings that are required to pay for this programme. So we're currently working out that business case for that expansion. We also recognise though that each programme, while it's important to have those four elements that I mentioned earlier, each programme will be different, will reflect the nature of its community and the different communities. We aren't expecting, as we expand across Bridgend, for it to look exactly as it does in the Garrow Valley or the Hindley Valley. We are expecting the programmes to look slightly different. We've also just completed an evaluation of through Wellbeing Wales, a commissioned piece of work to look at the well-being effects that this has had on the participants. So looking at how do we quantify that reduction in social isolation, that improvements in emotional well-being, so that we're not just focused on the reduction in waistline or reduction in BMI, but how do we actually quantify and put into numbers the benefits to society, benefits to the individual, benefits to the community of people having reduced socialisation, more independence, etc. Finally, across ABN, there is a ABN New Health Board. There is another study taking place of Bay Health Network, which is a very different demographic within West Swansea, and they're currently piloting this programme, a very similar programme. And part of our future work will be to look at comparisons between the two networks to see what future lessons can be learned from that. Okay, that was a bit of a race through, so if there are any questions, both myself or colleagues here will try and answer them.
Thank you. Well, lots of things there that have, I'm sure, provoked attention, questions, interest. Again, one of the things that I think came through to the judges was the strong evidence base throughout this programme. I mean, that's applied to the other entries as well, the other shortlisted entries, but that you were very able and ready to look at the evidence, to evaluate and to change things if necessary. Any questions? So Andrew. Andrew's eyeing this one up for his own health board, aren't you?
I think it might be.
I think it may have started when you were still with us.
It might be later. Yeah, a bit I'm interested in is to pick you up on the money question, because you said that we could ask it. I know earlier a colleague was saying that there are always obstacles in the way when we're trying to look for best practice. And in the current financial environment, to be able to say that you can spend the money we've already got better makes it easier for us to say yes, and hopefully you don't need necessarily formal business cases to emerge. Actually, down the structures, if you like, locally, people can actually start making these decisions themselves within their own respective budgets too. So I'd be interested on how you reconcile that kind of information as well, how to go ahead.
Yeah, absolutely. I mean, this I perhaps didn't come across well enough within the presentation, but this very much came from ideas from GPs, where they were seeing people coming into their practice, being prescribed Orostat, and they described it as a revolving door where they then go on Orostat, they'd be on it for a period of time, they'd lose some weight, maybe they wouldn't lose some weight, and then they'd be back, or maybe they even gain some weight, and then they'd be coming back in. So one of our tasks was to see, well, could we have a more effective service, but equally, because of the financial place where we're at, we need to be considering the costings of this right from the word go. So the Orostat, by not prescribing Orostat, covers around half of the costs of the programme, and then we are looking at, from the studies, from the reduction in other prescriptions of diabetic drugs, reduction in blood pressures, and although the numbers are still small around this, we're looking at from looking at patient notes, we're seeing a reduction for some around £40 per month per patient in other prescribing costs to pay for the remainders of the scheme. Now that's still, I think that needs to be scaled up, and there's more work to do around that. But fundamentally, key for us is, can we produce a better service, and can we do that in a way that's costed, so that I'm not going to our senior managers saying, we've got another good idea, can we build this into the budget? I don't know if any. No.
The biggest impact was on the diabetics, type 2 diabetics, and certainly in the initial evaluation, the biggest impact was on the diabetics. And they're looking at individual patient stories. Some patients had significant changes in their diabetic medication, and there was one lady who was about to go on to Senatide, which is what, £1,000 a year, maybe more than that, who didn't, or who was possibly being considered for bariatric surgery as well, who lost a significant amount of weight. And there were a number of patients that reduced their medication. I think if you wanted to start somewhere and look at a particular group of patients, the type 2 diabetics are the best. You'd start there and move about. The other thing to say as well is the Kangaroo practice, they had a very high prescribing of Orostat, whereas the other some of the other practices we were working with, they didn't. So you've got to look at the context in which you're starting it with, to say, because people are saying, well, look at this practice isn't prescribing it anyway, so well, okay, they're not prescribing it, but look at what else are they doing? Maybe they're not doing anything for their patients and they're still overweight. So I think you've got to understand the context, and that's why it's so difficult for the programme to roll it out, because you've actually got to look at each practice, what they're doing, what you've got in your community in terms of community activities and support you've got available to help those people as well. So it's a bit complicated.
Thank you, Dr. Khan.
Very important work that you're doing. What I want to ask is that when you start a project like this, one of the ways is that you are basically opening the floodgates and you very slowly overwhelm with the number of referrals or the amount of work that is generated. So, is there a criteria that you have used to filter who will be seen in this type of clinic, or those who would not be suitable for it?
Yes, there's a criteria. I don't know if Beth or Mel would like to talk this, so it's not my voice all the time.
Yes, there is a criteria. It goes with the NICE guidelines for community weight management program at level 2, which is a BMI of 28 with comorbidities, or a BMI of 30. And the main criteria that we encourage the GPs to look at is motivation as well. So whilst they want to encourage the most motivated patients to lose weight to come onto the program, because that will of course be linked to the success in their weight loss.
And they have to sign a contract so they sign a contract with the practice to say that they will complete 12 weeks. And theoretically they might be asked to pay back, and if not, but but that's what's in the contract.
So can I just ask you mentioned about the health broker law.
Sorry, I should have perhaps touched on. We were really conscious that we wanted to sustainability, weight loss is one element. Sustainability of weight loss is crucial. So we built within the programme what we're calling a wellbeing broker, but in England they're often called health trainers, or there are a range of other titles that they've been given. These are people, this is a person from the community, knew the background to the community, but it's not just, describe someone on Monday, it's not just signposting people who've finished the programme onto other activity that's going on in the community. They're based in the programme from week 1, from week 2. They're getting to know the participants within the programme. They know the different activity that's going on within the community, and they're looking to plug them into that community. So looking to plug them into classes, looking to, and those classes don't all have to be physical activity classes. Some of it's about reducing that social isolation. As the evidence, growing evidence, people aren't socially isolated, that supports that weight, that sustaining that weight loss. So if we can get people into knitting classes, we can get people into any sort of community activity, that's really crucial. Obviously extra benefits if it's a walking club, or if it's a club that's based around physical activity. So that individual is there very much, they know the class leaders, they know the different groups that are going on within the activity, and they're holding the hand of that person into that activity, breaking the ice initially for that person, and then going back to them, feeding back into that. How did it go? How was the class that you attended on Monday night? How did you find the leader? Or is that not for you? Okay, let's find something else for you to be doing. So very much holding their hand and supporting them into that sustained community activity. And sustainability of that longer term is very much a partnership approach. I mentioned the local authority. We're working very closely with Communities First, which is a regeneration programme. For those that aren't familiar with it, Welsh Government regeneration programme, and we're working very much with Communities First around developing that role.
Thank you. Any other questions at all?
That's fine. Can I just ask a follow-up? How are you evaluating? Are you doing that whole evaluation you're doing? Are you doing an evaluation of that broker role? Because that's quite key. Because I know nationally we've looked at the research and the evidence, because a lot of places are interested in the use of health trainers.
We haven't broken down specifically looking at evaluating just that role, although I think it's something we are looking at, because we want to ensure that continues to add value to the programme, and it isn't just personality led, or it isn't just about that one person's quite good at it, but then the big part for us in this is how can we scale this up across the health board region, and certainly how can we scale it up across Bridgend, and therefore it's about finding those key elements which are repeatable, and therefore we haven't focused specifically on that, but that is something we are considering.